This is kind of the second part of the T-cell exhaustion project. This part is actually focused on data. The first part, this is already up, focuses on the underlying theory. And the title here is Heterogeneity of Exhausted T-cell Subsets in Responders and Non-Responders Following Checkpoint Inhibition Therapy. So to recap, kind of some of the biology here, is that we used to think that T-cell exhaustion is binary, so cells would be exhausted versus not. But actually, as we now know, there are multiple states of T-cell exhaustion. So this is a great paper from 2020 by Beltre et al. That had this really great visual and was a good starting point here that we were working off of, in part. It turns out that only some states of T-cell exhaustion are susceptible to immune checkpoint inhibition therapy. So we called it reversibly exhausted cells as opposed to terminally exhausted cells. And then I was thinking, when I was even working through the first part of this project, thinking through T-cell exhaustion, why did this evolve in the first place? As I always say, cancer doesn't invent anything. It's usually some adaptations that evolved for a normal purpose that are then hijacked or used either out of context or out of proportion. So what is the case here? Well, it seems that subsets of exhaustion are actually characteristic of chronic viral infections, although they seem to be very similar to the ones in cancer. And this, in turn, most likely evolved as a mechanism of protection from autoimmunity, because our bodies always try to balance things out, and it could be less damaging for the organism to coexist with an infection long-term than to keep fighting it to elimination. Okay, so if that is the framework within which we're thinking, what would be triggers for transition to exhaustion in chronic infections? And then, of course, the question is, are they the same in cancer? So we were kind of discussing and thinking about it. One of the big kind of mechanisms that has been studied is prolonged antigen stimulation. I'm trying to think from the point of view, if this is a protection from autoimmunity, there needs to be some kind of a like a universal signal for this. So my thinking here was maybe some kind of systemic or maybe local inflammatory response, which will actually signal that, okay, there's too much local damage, too much damage happening to normal cells, we should slow down. And then further on, we were thinking, well, could this, the existence of these multiple states of exhaustion, only some of which are susceptible to checkpoint inhibition, could this lead to actually emergence of resistance to checkpoint inhibitors? In the previous work, the one that we did with Jan and Geverts, we analyzed the theoretical implications of the existence of multiple states of exhaustion. And we made several predictions that were then taken as a basis of this following work. So we predicted that, for example, T-cell composition with respect to different states of exhaustion would be different in responders versus non-responders. Makes perfect intuitive sense. Still good to see. So we had these simulations, and red is non-responders. We're doing protocol sweeps. You're very welcome to look at that paper, and also, as I said, I have a recording of that part of the exhaustion story as well. So red were responders, non-responders, green were responders. We were looking at what is happening there. And what we were finding is that if you have, so for example, top panel and bottom panel are non-responders, and the middle panel is responders. And we were seeing that, well, it seems like non-responders are predicted to have higher proportion of terminally exhausted cells compared to responders. Again, very intuitive, but nevertheless, needed to see that prediction. So here, yellow is a terminally exhausted cell. So these are basically dominating over time for non-responders, but in our responder population, actually, it's a different predicted composition. We did check whether there's a difference in terms of whether it's inflammation-triggered transitions or chronic antigen stimulation triggered transitions, and it actually seems that the predictions are within this framework, within this multiple stage transitions, are very similar. Of course, it's most likely that it's actually both to one degree or another, and we're going to discuss that a little bit more at the end. But technically, this still remains to be elucidated. Also, we predicted that T-cell composition with respect to exhaustion can be mediated by treatment. So it's not necessarily an intrinsic patient property of somebody is just not responsive, but might be not necessarily always, but might be also a consequence of how treatment is given, that it shifts T cell composition towards non-responder phenotype, and that's as well something that we were looking through. And so, inspired by our theoretical analysis, we then wanted to ask, can we actually see anything like this in real patient data? So in this particular project, we use single-cell RNA-seq data to check if these predictions are consistent with patient data. This work was done in collaboration with Clara Pavier when she was doing her postdoc at EMD Serono, or the German Merck, about 2 years ago. Okay, so the data set that we were using is the single-cell RNA sequencing data set from this publication, Luam et al. From 2022. The focus of that study was the relationship between T cell subsets and response to immune checkpoint inhibitors. Patients there were, so the data was taken from 27 head and neck squamous cell carcinoma patients in a phase 2 clinical trial. They were treated with neoadjuvant anti-PD-1 or anti-PD-1 combination with CTLA-4. That's just another checkpoint inhibitor. And sample types, so we had biopsies. We had the analysis of cells from the tumor microenvironment or also from peripheral blood mononuclear cells, so PBMCs. And the clinical readouts that we were working with were either pathological response, so classified into these three groups of less than 10%, between 10 and 50% versus 50% response, and also volumetric response, whether something was basically response or non-response. And we're going to look here through both types of these data. Okay, so as of right now, or at least as of when we were working on it, there were not very clear classifications of which cell types, which lineages to look through. So we tried to first categorize and organize our thoughts on that, on where to look. And so we were thinking, okay, the T cell differentiation process, you have naive T cells, the kind of the starting state of T cells, which upon activation can become effector cells, some become memory cells. And from there, you can have stem cell memory cells, you can have central memory T cells, you can have effector memory cells, C cells, and tissue-resident memory T cells. Kind of very broad classifications. Then we were thinking in terms of, okay, if you look at the states of exhaustion, of course, upon, as I was saying, upon chronic activation, like in cancer or infection, or as a result of systemic inflammation, or local inflammation, effector T cells progress through states of exhaustion, which can be tracked through specific transcriptional markers. And we used a lot of the data and information that was already, of course, available, like in the Beltro paper. We were trying to expand on that. And we were thinking that exhausted T cells can be categorized into following exhaustion subsets. So we're looking at early progenitor exhausted T cells, kind of further differentiated progenitor states, so separate these into two classes. Often they're lumped together, but we made a choice to actually, we found them to be different enough. Intermediate exhausted T cells, which are responsive to treatment, and also terminally exhausted T cells, which are highly dysfunctional and less responsive to immune checkpoint inhibitors. We also needed to find gene signatures as you're looking through the data, trying to figure out, okay, so which cells belong to which class or which subset. To map these in our data, we compiled transcriptomic signatures for each T cell differentiation exhaustion state. So these are the ones that we focused on. And we also did a comprehensive literature review and analysis of reference data sets, and that was conducted to extract these gene signatures. A lot of this analysis was done by Clara Pavier. I was supervising the project and guiding it, but this is really all her work. So as a result of this analysis, we found, okay, we have now this list of gene signatures. And so this heat map illustrates the expression levels of different gene markers characterizing each differentiated state. Red is upregulated, blue is downregulated. And it was very helpful to then, okay, now we actually, if we're looking at gene signatures, we can try to categorize and classify them. And I know that Clara did a lot of comparison of different methods, going through a lot of literature sources for this. So this was not from just one method, but going through and working through and reconciling multiple methods. A lot of this is in the paper if you want to follow through on this, get more details. Okay, so first we were looking at data on tumor infiltrating T cells. So from the tumor microenvironment, this is just kind of a snapshot of where we were starting. So of course we have the UMAP of subsets of tumor infiltrating lymphocytes identified through clustering-based methods. So we have this. We now have then more granular subgrouping of subsets of TILs based on like characteristic gene markers. So we have this going on here. And then we have UMAPs labeling predicted states projected onto the TIL subset space. So we were then splitting them up and seeing, okay, for all of these, what's going to be the corresponding exhaustion state. And this beauty is the alluvial plot, of course, looking at T cell classifications projections from multiple methods. We ended up largely using the elected method, again, all described in the paper, but then in general, so multiple methods were checked and taken and integrated in putting together this set of gene signatures and this analysis. Okay, great. Before we get to some of the results, I just wanted to go through a brief review of our selected lineages and T cell states, kind of what they do, their main characteristics, so everyone is on the same page on what we're talking about. I also personally find it very helpful to really have that put together to kind of have a reference for that. So we looked at CD4 versus CD8 T cells, and we found that CD4 T cells are actually seem to be less prone to exhaustion, probably lower due to lower antigen exposure, maybe because they primarily help through cytokine secretion, not through direct cytotoxicity, so maybe they do not need to be regulated in this way. In contrast, CD8 plus T cells, which are, of course, directly involved in killing tumor cells, they require strong activation, so they are, in a way, more dangerous. And perhaps that's why they evolved to actually have much more of these exhaustion programs. These are the killer cells, and they need more regulation than, for example, CD4 cells. That was really interesting that we found that exhausted states were actually primarily observed in CD8 plus T cells, with different cytotoxic T cell subsets showing different exhaustion states. So we often look at, do we have enough CD8 cells in the tumor infiltrating lymphocytes? Do you have CD8 T cells? Well, you can, but it's not necessarily an indicator of maybe successful response, because yes, they may be there, but as we're seeing, a lot of them might actually be in a terminally exhausted state. So that's something I'm going to come back to through this. We have naive T cells, present in lower numbers, predominantly in CD4 plus T cells. We looked at, of course, central memory T cells, so the majority of T cells across all groups. That was the categorization, as you'll see in the data. And they are crucial for long-lasting immune memory. They do show greater persistence and anti-tumor immunity compared to effector T cells, so that was interesting. Then we have a class of effector memory T cells. They are predominantly found in cytotoxic T cells in the tumor microenvironment. And they are the ones who provide long-term immunity and are kind of standing in the ready to respond quickly upon re-exposure to antigens. Very important. Now for the kind of states of differentiation, so effector T cells and states through exhaustion, those are short-lived, actively involved in immediate immune responses. Then our quiescent progenitor T cells, so the first program, they have low in vivo proliferation, but they proliferate upon antigen stimulation. So that kind of supports that maybe this is a combination, as we will see, of both chronic antigen stimulation and inflammatory environment in pushing the cells to go through the three stages of exhaustion. These are actually pretty rare in this data set, interestingly, so they were sparsely identified across different cytotoxic subgroups. Proliferative progenitor cells, so they're proliferative circulating cells, reduce cytokine production. They were amplified by PD-1 blockade, so they are responsive to checkpoint inhibition, and they are preferentially found in proliferating cells expressing Ki67 and other markers. Then we have intermediate exhaustion, intermediately exhausted cells, so they're circulating, mildly cytotoxic, they have reduced cytokine production. They have poor proliferation upon restimulation, and they are found often, so CD8 cells. CD8 cells are, as I would say, would be more These intermediate exhausted cells are more often CD8 cells, but they're not specific to any CD8 subset. And finally, we have terminal exhaustion. These are tissue-resident, non-proliferative cells. They could be apoptotic. They are enriched in interferon-related pathways, which we're going to come back to. And they are highly represented in granzyme-expressing T cell subsets. So these guys, they are short-lived, but they are also actually very cytotoxic, and that's an important piece here, and that's an interesting property of kind of how this states of exhaustion, how this has evolved. Okay, whew. Now finally we can look at some of the results now that we have the background done. First, we're gonna look at pre versus post treatment data. This was a very small data set. I'm just going to show this slide with the main figure, and then on the next couple of slides, I'm going to go through in detail through the pieces. So as I said, these are pooled responders and non-responders together, because we only had this complete data set for pre and post for only 6 of the patients. So we couldn't really look at the responders versus non-responders here, but still we found this to be quite informative. So this part, let's look first at immune cell composition changes. So we're looking at this class of cells. Are they helpers, Tregs, cytotoxics, or inconclusive? Couldn't really place them. So we found that post-treatment, we saw post-treatment increases in helper T cells, Tregs, and inconclusives. So this one also, these are just bar graphs, and this one on the y-axis, it's log proportion changes, as opposed to absolute, because it was much harder to see. But so as I was saying, you have these guys increasing and cytotoxics are decreasing. Interesting. We saw also increased helper T cells, which may indicate maybe adaptive support of immune functions. Maybe there is a transition to regulatory phenotypes. Don't know. This is interpretation. Right now we're looking at data, but the thinking here was that maybe increase in Tregs may account for this decrease in cytotoxic T cells as part of an immune regulatory mechanism. So as treatment beefs up the cytotoxic T cells, the regulatory mechanisms kick in to balance it out, to actually prevent autoimmunity. Again, we're going to touch on that more in subsequent slides. Okay, so now let's look at the state changes. So before we were looking at kind of cell type changes, let's look at the state changes. So we do see some significant increases in terminally exhausted T cells. Interesting. Makes sense if you think of, again, immune system gets beefed up through checkpoint inhibition, and so this is a way to then put a damper on it to not have autoimmunity. Increase in progenitor exhausted T cells, again, so pushing down that pathway, and effector memory cells. But we do have decreases in effector T cells and, interestingly, progenitor exhausted T cells. So it seems like post-treatment really pushing it further down this exhaustion pathway. And we do see, interestingly, also increase in intermediate exhausted, but a decrease in intermediate exhausted, but increase in terminally exhausted. Again, going down further down that pathway. We have some subtle changes in memory and naive cells. So in some central memory cells, naive T cells, there seems to be a bit of a shift maybe towards naive-like states. This is more for interpretation and kind of from the observations. But what, again, I find interesting that you see this decrease in effector T cells and increase in exhaustion-related states. To me, the fact that there is such a difference between pre versus post suggests that treatment could be factored in inducing some of these transitions towards exhaustion. Again, if you think about it evolutionarily, as the body is adapting, that the drug is now activating your immune system, and the body is responding by, whoa, do not make it too dangerous, protect from autoimmunity, and so actually starts putting on the brakes with that, and then this causing this transition towards more further down exhaustion pathways. Okay, so second piece, so that part of data that was really interesting, but as I said, only 6 patients. It would be great to see more detailed analysis of pre versus post. Would be very interesting to see pre versus post on responders versus non-responders. something that is left for future work. Now let's look at post-treatment of responders versus non-responders. Again, this is just a snapshot of the figure, and I'm going to go through different pieces of it in the following slides. So first we looked at volumetric response of responders versus non-responders. So non-responders on the left, responders on the right. Once again, so this is both post-treatment, and once again, looking at kind of these cell classes. So what we do see is responders have higher proportion of helper T cells compared to non-responders. So, okay, maybe this suggests that helper cells aid in better immune outcomes. Tregs are also elevated in responders, but as I keep talking about it, that maybe is actually an indication that the immune system is trying to put some brakes on it, and it can do it through either upregulating Tregs or pushing the T cells, cytotoxic T cells, further down the exhaustion pathway. Non-responders have more cytotoxic cells compared to responders. That was interesting, but if you remember from our beautiful UMAPs, these cells are more likely to be in a terminal exhausted state. So they are actually probably not as helpful and functional and supportive of the response. So this also to highlight that we should be looking not just at what cells are there, but what state they're in. Now, this one is looking through actually the distribution of different different cell states, how far they are, different exhaustion pathways for responders on the right and non-responders on the left. So what do we see here? We see, of course, responders have higher central memory T cells versus non-responders. Okay, so maybe something more sustained immune response is interpretation from these, like this is observation. Right now, my commentary is more of how we're interpreting this. Non-responders have slightly more effector memory cells and, effector cells, but overall proportions are actually surprisingly low in both groups from the samples that we had. This was really the main thing that is actually very consistent with exactly what we were predicting with our very basic conceptual mathematical model, which nevertheless captured this, which is that terminally exhausted cells are actually significantly higher in non-responders, about 10%, versus less than 4% in responders. And these our intermediate kind of progressor cells. They are higher non-responders than responders, but this one is pretty small differences. And really, for me, very big interest was how many more terminally exhausted cells were in non-responders compared to responders, which, as I said, really fits well with our theoretical predictions. But this kind of suggests that maybe more cells are further down the exhaustion pathways in non-responders, and maybe that is starting to limit reactivation, because they might not be targetable cell states. Okay, now let's look at volumetric versus pathological response. So here we have binary no response versus pathological. They're kind of these low, medium, high response rates. So in both cases, they show higher helper T cell proportions and better responses in responders versus non-responders. Again, non-responders show higher cytotoxic T cell proportions across both data sets. But of course, we know that just presence alone is insufficient. We need to actually look at the state in which, so where in the down the exhaustion pathway the cells are. And interesting also, Tregs are a little bit elevated and better responders, which to me, again, this is an interpretation from more an evolutionary point of view. This really indicates that it's a controlled regulatory environment, which may be key for effective responses. Not too much, not too little. There seems to be some Goldilocks situation here, and we're going to come back to that a lot. Central memory T cells dominate both groups. Okay, so maybe a reservoir for long-term immune responses. And we also looked at helper T cells and Tregs and response types. So we wanted to see how much consistency there is between volumetric analysis versus pathological data collection. And it seems like pathological response data shows a more consistent increase in helper T cells and Tregs correlated with better outcomes. Volumetric data has more variability. And the second program like of progenitor exhausted cells. Okay, also slightly higher in pathological responders, but they decrease in volumetric responders. So we were not sure what really explains these differences. Is it how the data were collected? So the sampling timing differences, is there something else here? So we were looking for also both similarities and discrepancies in looking at the data from these both points of view. Okay, now to the next part of the story, which is the inflammatory markers in responders versus non-responders. And so for this part, we wanted to look at inflammatory signatures in responders versus non-responders. As you remember, I was talking about, so is it chronic antigen stimulation that pushes T cells down the exhaustion pathway? Is it more of a kind of systemic or at least local inflammatory environment? So we wanted to look at the inflammatory signatures. Once again, just giving a big view of the data, and then I'm going to go through it piece by piece. But the goal of this part of the analysis was really to assess the level of inflammatory response in responders versus non-responders. And we had an option to look at different markers, but we really focused on interferon gamma signaling in both volumetric and pathological response data. And once again, I'm going to keep driving this point home here, is that it seems like extreme interferon gamma signaling in either direction appears to be detrimental to the immune response. So it seems like tumors can be too hot and not just cold versus hot. Okay, so first, before we get into this, these are some violin plots of interferon gamma signatures across different T cell states. And this was just so interesting and kind of obvious that we even drew lines through the median. But it's so interesting that you see how, as the cells go through different exhaustion programs, this signature score first decreases and then increases. So sensitive to maybe inflammation here, sensitive here, less here, or that there's some kind of, there is a pattern here that we're going to be looking through. Also, we'll be talking about classifications of scores as low, medium, and high, the way that that was defined, that you have, okay, here is where you are in your medium, and then standard deviation to the left, to the right would be low versus high. Okay, so let's first look at effector T cells. So these guys. Looks like non-responders. So non-responders here, responders here. Non-responders have more, actually, of these cells in low interferon gamma signature, so more like a cold tumor. Responders show a higher proportion of medium and high interferon gamma signatures. If we look through these here as well. Interesting. Responders, effector T cells seem to be maintaining a more activated state with better interferon gamma signaling. So maybe this is contributing to more effective immune responses. But non-responders have fewer active effector T cells. So maybe that impairs their immune response. Don't know. But these are just kind of, we're looking at the data and we're trying to understand what are the patterns, what it is that we're seeing, and how can we make sense of this. Now let's look at just like we're going to go through all of the programs one by one or two by one. So these are these two progenitor states. Okay, so this program, so what do we have here? We see that both groups have medium interferon gamma as dominant in this for progenitor 1 cells, but responders seem to have more cells with medium interferon gamma, so potentially this means a better reactivation potential. Non-responders have 50% more low interferon gamma progenitor 1 cells, suggesting more maybe exhausted or dysfunctional cells, maybe not as sensitive to it. With progenitor 2 cells in both groups, high interferon gamma dominates. Interesting. Responders have fewer low interferon gamma progenitor 2 cells, so maintaining them in a less exhausted state with maybe higher potential for reactivation, don't know. And non-responders have high interferon gamma in these progenitor 2 cells. Maybe that's what is pushing them further down the exhaustion pathway. So that's how we were trying to think through what do all these changes mean. Finally, the last two classes, so this intermediate exhausted cells, seems like high interferon gamma signature is dominant in both groups, but responders have a higher proportion of that. So maybe there is active engagement despite exhaustion in the responders versus non-responders. Non-responders have more of this low interferon gamma intermediate exhausted cells. Maybe that indicates potential dysfunction, reduced ability to contribute to immune responses. And finally, for terminally exhausted cells, so this last column everywhere over here, you can see everywhere it's all like medium and high, medium and high. But responders have 25% more of this high interferon gamma terminally exhausted cells, while non-responders have slightly more low interferon gamma terminally exhausted cells. Also, it seems like high interferon gamma and terminally exhausted cells maybe still plays a role in tumor control for responders, but low interferon gamma in non-responders maybe suggests to us the way that we're interpreting it as deeper dysfunction. And more interestingly, to me at least as we were discussing this, it seems like both volumetric and pathological data, they do suggest that the way that I'm seeing it, that it is, again, about a balance, about not being too high or too low, and that seems to be better associated with responses compared to non-responders. So it does seem like maybe extreme interferon gamma signaling might be actually detrimental to immune response, kind of all going towards this idea of it's about a balanced immune response as opposed to just heat it up as much as you can. Okay, kind of final part of this analysis, we also wanted to look at the comparison between peripheral cells versus the ones in tumor microenvironment. Because we saw clear differences between responders and non-responders in the tumor microenvironment, in the tumor infiltrating lymphocytes. But of course, they require biopsies, they're much harder to obtain. It would be much nicer to be able to sample peripheral blood and check if the same patterns hold there. So that's what we wanted to see. We repeated the analysis for PBMCs to see if the differences that we did see in responders versus non-responders can actually be observed in the periphery. So to compare, this was this plot for the TME, and this is the same analysis but done for the PBMCs for the peripheral data. And of course, you can see that the distribution of T cell identities in PBMCs is quite different from that in tumor infiltrating lymphocytes. Like most helper cells are clustered in the naive T cells, in contrast to TILs, where TNs are kind of composed of both helper and cytotoxic cells. Also in the TME, most of the cytotoxic cells were in the terminally exhausted state. So these guys over here, cytotoxic over here, but it doesn't seem to hold for PBMCs. And as we looked further into it, these pre versus post-treatment differences in PBMCs, they do not mirror, unfortunately, what we saw in tumor infiltrating lymphocytes. So key patterns that we did see in TILs where you had high central memory cells, you had a lot of terminally exhausted cells, you had increased proportions of cytotoxic cells and Tregs. But in the PBMCs, this is not something that we have observed. In PBMCs, you have a higher proportion of actually naive and central memory cells. Terminal exhaustion is minimal in PBMCs. Really the big marker and mechanistically the piece that makes the most sense. We are not observing those increases and those differences in responders, non-responders as we did for the tumor infiltrating lymphocytes, which of course also suggests that really it is maybe much more driven by a local microenvironment than something more systemic. Localization of exhaustion, so in T cell exhaustion memory are more localized in the TME, not reflected in circulating PBMCs. And so the responder versus non-responder patterns, we were not able to see significant patterns differentiating responders from non-responders in PBMCs compared to what we saw in the tumor infiltrating lymphocytes. So unfortunately, no, you actually, if you want to see these differences, peripheral blood does not have enough of this information, and we have to actually look at the tumor microenvironment. Okay, final few words on the topic. So to summarize kind of the key results of this work, we do see differences between responders and non-responders with respect to states of exhaustion. in tumor microenvironment. Terminally exhausted cells are more prevalent in non-responders, consistent with our prediction and also with just basic logic. We do see differences in pre versus post-treatment data, so suggests that emergence of resistance potentially then could be mitigated through maybe different therapy administration, different schedules, timings. Some of that was explored in our original work with Jenna Geverts, and some of it I'm actually going to get back to in a moment. Analysis of interferon gamma expression in responders versus non-responders suggests that inflammation could play a role in triggering these transitions through multiple states of exhaustion, and like kind of coupled with the observation that you have higher Tregs and responders, it does suggest that really we are looking for balanced immune response, and that's what is critical for efficacy. So what we're seeing is that this dichotomy, that non-responder tumors, it's not that, oh, they're cold and responder tumors are hot. That it is that you can have non-responders can be cold, insufficient immune stimulation, or too hot. Too much inflammation may also be triggering these transitions to terminal exhaustion, and that is a thing that might also be a mechanism of emergent resistance. While responders seem to have more of a Goldilocks balanced immunity. Finally, so there are some differences between responders and non-responders that we did observe in tumor-infiltrating lymphocytes, but unfortunately they're not reflected in the peripheral blood. So it's not informative in this regard, and we do need to go for tumor microenvironment. We also started looking at peripheral cytokines, but that does not seem to also reflect these differences either. Key limitations of this analysis are, of course, it's a very small data set, especially pre versus post. It would be wonderful to repeat it for larger data sets. And it would be even more wonderful to have more granular longitudinal data to look at. So kind of bringing it back to this whole, as I've been alluding to throughout this, cold versus hot tumor paradigm. So this is a figure I adapted from BioRender. We used to think, we keep thinking, it's like, okay, standard is cold tumors, you have lack of response due to insufficient immune stimulation, that makes perfect sense. And then a warm or hot tumor, then, okay, you have sufficient immune stimulation and everything is working. But what we are seeing here is that maybe there is also such a thing as too hot tumor, and where lack of response is not due to insufficient stimulation, but through excessive immune activity, which does trigger all these anti-autoimmune mechanisms like transition to terminal exhaustion, which is not targetable, at least right now, increase in Tregs, everything possible to tamp it down. So you might actually have more of this bell-shaped curve here, as opposed to just kind of cold, warm, or hot dichotomy. Okay, well, interesting. So can this be mitigated? Excellent question. So we actually, about 6 months after we published our theory paper, we saw a couple of these very interesting 2 separate clinical trials that appeared that found that if you combine checkpoint inhibitors with anti-inflammatory drugs, like these trials we're looking at JAK inhibitors, that can actually improve the effectiveness of checkpoint inhibitors and sometimes even rescue response. So these were the 2 papers that came out. Then they were looking, so this solid tumors, metastatic non-small cell lung cancer. As monotherapy, you had under 50% response rate, but once combined with a JAK inhibitor, not only did you have a high response rate, but you actually had much longer median recurrence rate, which is fantastic. This study of Hodgkin lymphoma, the enrollment criterion, this is even more dramatic. The enrollment criterion was that patients who did not respond to immunotherapy at all, to monotherapy. But when combined with a JAK inhibitor, they saw 53% response rate with 46% showing no progression after 2 years. That's remarkable. And they also found that it was actually essential to appropriately time the anti-inflammatory drugs relative to checkpoint inhibition. That if you are giving it too early, then, you are tamping down the immune response before it has a chance to ramp up. So they found that you actually need to first give checkpoint inhibition, then you need to do the anti-inflammatory to kind of mellow mellow the immune system out a little bit. So I guess it doesn't trigger transition to terminal exhaustion. That's my interpretation. That, of course, is not something that they talk about there. But this is kind of how, within the frameworks of what we've been talking about, that's how I would interpret it. And of course, when I see things like that, I get very excited because this is perfect application for mathematical modeling and optimizing and figuring out how to make this work, the timing work for most patients. So this is, I find, to be an extremely exciting area. Just kind of a little bit of a closer look at specifically the solid tumor one, the non-small cell lung cancer. So this was a phase 2 clinical trials with 21 patients, and they were treated with pembro and delayed JAK inhibitor, itacitinib, for treatment-naive metastatic non-small cell lung cancer, and this was the inclusion criterion. And what they did show was, like the qualitative responders, the responses were that responders had decreased expression of terminally exhausted CD8 cells and increased expression of reversibly exhausted cells. So very much consistent with what we were finding in the data set that we were analyzing here, the differences between responders and non-responders. And as opposed to progressive disease, you had the opposite trends, with plus high baseline inflammation that was minimally changed by JAK inhibition. So this is one where they were just not able to mitigate the inflammation. And so that continued pushing the T cells down the exhaustion pathway. So this really, at least the way that I see it here, understand these data, this does fit very much within how we are starting to understand these interactions and exhaustion pathways. And I find this to be really, really exciting, and looking forward to seeing more work and more data on this topic. Okay, final slide. So on the left, this is the original theory paper that we did with Jana Gavertz, kind of making these predictions, and this is the work that I'm summarizing here and now, looking at single-cell RNA data. Okay, thank you very much for your attention.